In continuation and evaluation of the anterior hip, after we have obtained the position for injection into the iliopsoas, and this is only one of many techniques that's implemented, you want to take a look at the iliopsoas conjoint tendon in its long axis. Once you find it sitting superficial to the femoral head, you will see this conjoint tendon area by turning the transducer clockwise. You'll see the tendon structure in its long axis. It is often difficult to follow the iliopsoas tendon all the way down to its insertion on the lesser trochanter unless the patient is in a frog position, and can be difficult for patients that have hip pain. Moving the transducer back up, rotating the transducer back into its short axis. We're going to move the transducer slightly lateral, and once again we're going to pick up the short axis of the anterior inferior iliac spine, and you'll see the more of the iliacus muscle, which is more on the medial aspect. Once locating the anterior inferior iliac spine in its short axis, you'll see the direct head of the rectus femoris sitting just superficial to it. Now, I'm going to switch hands so you can see my rotation, and using two-hand rotation, I'm going to turn the transducer to a long axis so the transducer orientation is pointing towards the patient's head. And then we're going to see the direct head of the rectus femoris insertion onto the anterior inferior iliac spine. So this would be the direct head of the rectus femoris. You will also see on the right-hand side of the screen where the arrow is pointed to a dark shadow that's almost in a curved linear that's headed down towards the acetabulum, which is the area of the indirect or reflected head of the rectus femoris as it comes down and inserts onto the area of the acetabulum. For visualization of this, I'm going to change to a lower frequency transducer so you'll actually be able to see the insertion point. Switching to a lower frequency transducer, I'm going to increase the depth a little bit, and I'm going to once again point out the area of the anterior inferior iliac spine, the direct head insertion onto the anterior inferior iliac spine, and the shadow of the indirect or reflected head as it turns down towards the acetabulum. To evaluate the reflected head, we need to move the transducer out laterally and then direct it back towards the acetabulum. And at this point, we can see the insertion of the indirect or reflected head onto the ridge of the acetabulum. The reflected head is a common site for calcific tendinopathy to occur.